I'm Marlee Krieger, and I'm the Executive Director for the Center for Global Women's Health Technologies at Duke. And for the last 4 years, I've served as one of the lead instructors for a BAS Connections course, which aims at increasing the local adoption and distribution of a low-cost colposcopy device called the pocket colposcope. And I have my co-instructors here on the call for the last year of that course. And we're going to talk to you today about our field work and our goals associated with the fall 2019 and spring 2020 class.
Hi, my name is Andrea Thoumi, and I'm a research director in global health at the Duke Margolis Center for Health Policy and assistant director of research at the Global Health Innovation Center. I have been working with the WISH team for the last year and have been a co-instructor on the BAS class.
Hello, my name is Libby Dotson. I'm a research associate in the Center for Global Women's Health Technologies at Duke and have been working with this course for 2 years as a co-instructor.
So let's take some time to talk about what we aim to achieve within the course and how the pandemic has affected not only the goals during the semester, but then also how our goals have evolved after the semester has completed. So I think let's summarize the goal of this year. Really, we had 3 projects which focused on an area that we believed could improve the acceptability and ultimately the adoption and scale in Peru, which is one of our flagship countries where we've implemented our low-cost screening device. And the projects were separated into 3 major themes. And the themes were related to the economic costing associated with the pocket colposcope, the clinical acceptability of the pocket colposcope, and then also the political implications surrounding the adoption of a disruptive technology in a low and middle income country. And we know that Peru is a middle income country. And what we did was we spent the semester training a group of talented undergraduates across multiple disciplines. And really that culminated in a field experience when we took the students into the field in Peru over spring break, which was March of this year. And as we all know, that's in the midst of the pandemic. Events were really beginning to unfold for us at that time period. And so we went into the field with a lot of uncertainties. Obviously, the trip still happened, and we were able to successfully accomplish our field work, but it was certainly a precarious situation because we as instructors didn't have all the information that we needed regarding travel. We hadn't received guidance from Duke about whether or not we should go into the field. And ultimately, we decided to continue with the field experience. And fortunately, no one became ill as a result of the trip. We were all able to successfully make it home, but we did really have to change our original goals being on the ground and what we're actually able to achieve. We were originally slated to conduct field work in 2 regions in Peru, and as a result of COVID-19, we had to all focus on one area. The area that we were able to focus on was an area called Ventanilla, and we were able to focus our efforts on primarily the acceptability project, where we had our students interview community health workers on their perspectives related to cervical cancer screening and also related to our low-cost devices. We were unable to do as much as we wanted with the costing and policy projects, but it turned out to be quite beneficial because we really did need all of the students focusing their efforts on the clinical acceptability. Now, Libby, you also had a sub-project that was distinct from the Basque Connections course. You led a training program on a related device. Can you talk about that program?
Certainly. Thanks for asking. And so in addition to the work that we did as a team for the Basque Connections course, a subset of students also worked with a second device, which is called the Caloscope, which is actually a speculum-free imaging device for women to be able to self-image their cervix from the comfort of their homes. And while this is not a device meant to, well, really, the pocket colposcope and the Caloscope, they serve two different purposes, whereas the pocket colposcope is more for use within the clinics in these different communities, and is a low-cost option compared to the really expensive standard of care colposcopes. The Caloscope is really meant to replace another form of screening called visual inspection with acetic acid, and allows a woman to complete that process from home. However, we're much earlier in the device development stage. As we all know, these devices take several years to go from a really great idea and the bench in the lab to an actual community and an intervention that's successful in that community. And so we're at an earlier stage with the Caloscope device in the pocket. And right now we're trying to understand, you know, the women in different communities globally, is self-imaging something they're even willing to do? How acceptable is that to them? How comfortable is the device? What design modifications should we make? And really, what do we need to do on the engineering side and the public health, the intervention development side to bring that device successfully into the community? And so a group of ladies called Hope Ladies in Peru, and Hope is a program started by Dr. Patricia Garcia at Cayetano University in Lima, where university staff train community leaders in Ventanilla about the human papillomavirus, HPV, about self-sampling. So very similar to the Caloscope's idea of self-imaging the cervix, you can also now collect your own sample and test for HPV, which is a precursor of cervical cancer and leads to the majority of cervical cancer cases. And so these Hope Ladies were already primed on cervical cancer. They know a lot about it. They've been working in their communities for several years in Ventanilla, their community, and teaching, going door to door and asking women if they're willing to participate in self-HPV sampling. And so our vision is that the Caloscope would eventually be a triage method for HPV positive women. But back to the study, we worked with 15 of these Hope Ladies, these community health workers, and they took the device home after a day of training, or about 3 hours of training, and attempted to image their cervix. And so 2 of the pocket participants helped with this, and this happened at the same time that the activities for the Pocket Basque Connections course.
Libby, thank you for that. I think that's a great segue into one of my questions, which is related to interventions such as this. And so, Andrea, I'd really like to have your opinion, given that you're from the Margolis Center for Health Policy. Are these interventions, such as HPV self-screening and the Caloscope and pocket colposcope, are these the types of interventions that engineers and members of the public health community should be focusing on? And if not, what are the types of interventions that we need to focus on that will make significant impact or improvement in not only Peru, but also in the United States as we all evolve during COVID-19?
With regards to community-based interventions, I do believe that COVID has actually really highlighted the structural inequalities and some of the paradoxes that exist in countries around the world, whether it is in the US or whether it is Peru. I think in the Peruvian case, the a very large paradox is that the country has been growing at a very high rate over the last couple of decades. The country has been averaging about a 6% growth rate. Despite that, the country does have massive inequalities, and this is because the Peruvian government has reinvested into the productive sectors of the economy. And this is the case in many low and middle income countries, and a strategy that they often do. What COVID has really highlighted are the structural inequalities that are both entrenched in the actual society, and we saw this, and I think that it was really great for the best class to go on this field trip to Peru. They saw the different social determinants of health, and that really are the roots of the health disparities in populations. And again, this can happen in any country, as we are seeing also in the US right now with how health disparities are, how COVID is highlighting the health disparities that exist in the States. Likewise in Peru, COVID is actually COVID is actually hitting the lowest income populations the most. So I do think what is challenged before, I think that health systems do need to be moving towards community-based models. However, COVID has really shown the importance of this. And I think that essential services such as reproductive health or primary care services are going to be, we'll have to be rethinking the model of how they are provided. And this means not just strengthening primary care, but also identifying different interventions, such as the pocket colposcope and the caloscope, that can be used in different clinical settings, whether that is in the health facility, that is the closest facility for women to access, or whether it is in their home. And I do believe that engineers, as Marlee, you mentioned, I do believe that it would be important to identify these types of interventions that are really locally driven. And I thought on a prior trip, when we actually visited Peru in August, we did join a couple of the leading engineering programs in the country. And we saw how the engineers were identifying locally, they were identifying local problems and local solutions. So what this also means is, developing low-cost technology that can be done in country, and really developing solutions that are based on the local problems. And I do think that the partnership that Hope has with Cayetano is one pathway forward, and with the Catholic University of Peru as well. Those are the two universities that have the leading engineering schools in the country. And I do believe that these types of solutions that combine local innovations to local problems are going to be the way forward. I will say that in addition to innovations, it's very important to think about what the policy challenges are, what the cost challenges are, what the different organizational capabilities are. So it's a comprehensive solution. So it's not just about the innovation of itself, but it's about a comprehensive solution that identifies the local problems and the local needs and develops local solutions.
Thank you for sharing that, Andrea. I think it's really important to underscore those social inequities that you've identified and that we've also identified as being part of this experience. That leads me to my next question, and I welcome responses from both Libby and Andrea related to this. I wonder if, based on not only your knowledge, but then also our experiences on the ground while in Peru and then returning home, can you compare and contrast the general readiness of the typical Peruvian household versus the typical US household for a pandemic like COVID-19?
Sure. So with regards to readiness and whether the typical American or the typical Peruvian household is prepared for COVID or other pandemics in the future, I do think what COVID has shown is that the majority of households are not prepared. And I think that this is also tying back to the social inequities that exist across countries and within countries. So, for example, in Peru, the average Peruvian household only has 4 to 6 weeks of savings at best. Many workers, the majority actually of workers in the country are day laborers or in other informal sectors of the economy. And so what that means is that a family might have enough to cover a couple of weeks of food, of rent, but past that, they're not going to have sufficient resources. And we've seen this play out right now of what's happening in Peru, where a number of families are actually, they've been evicted from their houses. They're now moving back. There's now an internal migration going back from the city to the rural communities. Before, 20 to 30 years ago, it was actually the reverse, where families were moving from the provinces to Lima, where there was opportunity, economic opportunity, to be able to work. However, now they're going back to their houses, their families, back in the provinces, where they might have a plot of land, or their family might have a plot of land, and they would be able to go back to those households. And I think that actually COVID has also has also highlighted another systematic challenge, which is food security. And a lot of what's happening right now also in Peru is around the lack of food security. And we see this also with lines at the supermarket, for example, where people are now waiting. There are reports of people waiting up to 8 hours a day to be able to get food. The markets have also been the hotspots of COVID-19 in Peru. However, despite calls to close the markets, that's not a feasible solution at the moment. So even though we know that the markets are hotspots, people do need food to eat. And the challenge is that the average household does not have enough money to be able to purchase food for a long period of time. In addition, another structural issue is actually refrigerators, where only 1 in 5 households in Peru has a refrigerator in their house. So that also just shows you that without a refrigerator, for example, the households are not able to keep food fresh for a long period of time. So then that also creates an incentive to go to the supermarket, or to have to go to the supermarket more frequently than you might need. And again, I think, and this is something that we're seeing in the US too, of many of these communities, despite public health measures of wanting to, or despite the public health measures for social distancing and staying at home, there are many people that are not able to do that for a number of circumstances. And in both of these countries, actually in both Peru and the US, I do think that there are structural issues. In the US, there's also structural racism. And so I do believe that there are these underlying factors that we know exist and that we've known have existed, and we know how they have played out, and COVID is just shining a light on that now.
Andrea, thank you for sharing your thoughts in a Peruvian but also US context. In somewhat similar, when you say that most families only have 4 to 6 weeks of savings, I think sometimes that's what we would observe in the US as well. Libby, I'd like to turn this over to you. And I know that you are from a more rural community in North Carolina. Can you add anything about generally what you've observed about the general readiness of families, and including those with whom we visited in Peru, and then based on your experiences being back in North Carolina?
This crisis is exposing a lot of issues in rural healthcare, and some that I've personally noticed here in North Carolina. And in particular, when it comes to services, preventative services such as cervical cancer, there's a lot of tension right now in these rural parts of the US with people who are having to make difficult decisions between going back to work and not feeding their family of four. And there's a lot of partisan divide around this, but I think that healthcare, accessing healthcare, and being able to support your family are really valid concerns that people are having, especially if the economy continues to be shut down. And it's a bit difficult to see both sides, those who are fighting for bigger restrictions and those who seem to be fighting against it. It's difficult to watch that play out when really you understand that, you know, deciding between healthcare and having a income is a difficult decision. And this really affects reproductive healthcare because, I mean, I can speak for myself. It's hard enough right now to just get an appointment with, I was having a really hard time getting an appointment with my family doctor. It was like 3 months out when I was home for about a month. And so you can imagine, I can't imagine trying to get an appointment in rural North Carolina with a gynecologist. It's pretty difficult. So those are some of my personal experiences, and some of my worries around reproductive health is these sort of what we consider preventative, like, oh, we go annually to get a pap smear, are kind of falling to the wayside just because of how the system is clogged with people wanting to do telemedicine, and a lot of rural like primary care facilities not having those capabilities. There not being broadband access. I was in the Appalachian Mountains this past weekend, and it was like nothing had happened. Like there was no virus. There was no one in masks. It's just very eerie, the rural urban divide, because here in Durham you go outside and everyone's wearing a mask. So those are just some of my observations.
Libby, thank you for sharing that. I think it's interesting to hear about the changes that are happening within families, but then also with healthcare itself.